So, welcome everyone to the fourth edition of the IFS BSV Convergence Initiative. This is about bringing awareness towards the Endometriosis Awareness Month, that is March, which is celebrated globally. Today, we have the galaxy of stars on this program. We have expert Dr. Roman Horace, moderators Dr. Sudha Prasad and Dr. KD Nair for a very unique topic. We want a lot of questions from the audience so that we can ask Dr. Roman Horace to share his experience on the same. Let me first introduce our first moderator, Dr. Sudha Prasad, who is the current president, Indian Fertility Society. She's been the vice president, FOXY, for 2019. She's the former director, professor, and IVF coordinator at Maulana Azad Medical College, New Delhi, former dean, Faculty of Medical Sciences, and many other accolades to her name. Welcome, Dr. Sudha Prasad. Then we have Dr. KD Nair, Dr. Kannad Dev Nair. He's a senior consultant and HOD at Akansha IVF Center, Mata Chandan Devi Hospital, New Delhi. He's the current president-elect for Indian Fertility Society, convener for the Education Committee, IFS, from 2018 to 22, and many other positions across associations. Welcome, Dr. Nair. May I request Dr. Sudha to kindly take the proceedings forward.
Thank you, Session. I welcome Dr. Horace Roman in this initiative, which is the Endometriosis Month. Dr. Roman is surgeon of endometriosis at Endometriosis Center of the Clinic Tivoli Ducos. He is the honorary professor of Aarhus University, Denmark, PhD in epidemiology. His practice and clinical research exclusively focused on surgical management of patients with deep endometriosis, which is a very tough clinical problem. And he has the experience of more than 1,000 colorectal endometriosis, 250 with urinary endometriosis, 70 with nodules of sacral plexus and other rare localization. Has a publication more than 200 articles. I really salute you. You have taken a very big task on endometriosis, Dr. Roman. And you are going to, today, you are going to speak on the deep endometriosis, how to excise it. So floor is yours, and you please, everybody is waiting for your talk.
So thank you very much. Thank you very much for your kind invitation. It's a pleasure and an honor for me to be with you virtually. Do you have my screen?
Yes.
Perfect. So I will put the screen like this. Perfect. So it is my great pleasure to speak to you about a rare localization of deep endometriosis, but it is not very rare now, because I have more and more patients coming to seek care with this localization, and most of them also have infertility and previously have had 1, 2, or 3 IVF. So it is very likely that once you will meet this kind of patient, and it is important for me to recognize the disease and to know how to manage them. So the objective of my lecture is to give you some tips and tricks which may help to guide the excision of deep endometriosis infiltrating the parametrium down to sacral roots, and also to prove you that this surgery is feasible by experienced surgeons, and the results may be very good. And after the surgery, the patient may come back to you to continue the management in IVF, the management AORT. So first we will speak about the parametrium. So as you know, the parametrium is this region located between the vagina, rectum and bladder medially and the pelvic wall laterally. And in this parametrium there are a lot of vessels, there is the ureter, and there are the nerves. Big nerves such as the sacral roots and the sciatic nerve or obturatory nerve, and very small nerve, very thin nerve, such as hypogastric nerve and the splanchnic nerves and the inferior hypogastric plexus. So if you speak about the sacral roots, there are 4 sacral roots, and they join the 4th and 5th lumbar root in order to give birth to the sciatic nerve. So the sacral roots are located very deep into the pelvis, just in front of the piriform muscles. And to reach them, you have to go behind the hypogastric artery and the hypogastric vein. You can see here the hypogastric vein, and here you see the 3rd sacral root. So they are white, and always their direction is from medial to lateral and caudally. If we try to imagine where the sacral roots come from, you have to look at this picture. So we have the lumbar plexus and the sacral plexus. We have the L2, L3, L4. They will give birth to the obturator nerve. The obturator nerve has nothing to do with the sacral plexus, but it is located into the pelvis close to the fibers from the sacral plexus, so it is very useful to know where it comes from. Then we have the L4, L5 and S1, S2, which give birth to the largest nerve of this region, which is the sciatic nerve. Then we have fibers coming from S2, S3, S4. They will give birth to another nerve, the pudendal nerve, which is not very easy to see into the pelvis, because it goes out below the sacrospinous ligament. And then we have very small fibers, which are the splanchnic nerves, which join the hypogastric nerve, which brings sympathetic fibers, and they will give birth to the inferior hypogastric plexus, which will command the function of the rectum, of the vagina, and of the bladder. So these are the nerves we can find into the parametrium. Now, the hypogastric plexus, it is a very, very thin anatomical structure, so it is much more difficult to see than the sacral roots, which are large. You have to know that the inferior hypogastric plexus is located somehow below, in the plane of the ureter, below the ureter, and it receives sympathetic fibers from the superior hypogastric plexus via the hypogastric nerves, and parasympathetic fibers coming from the sacral roots via the splanchnic nerves. The function are motor, sensitive, and vegetative. And this inferior hypogastric plexus, when you have a deep nodule of the parametrium, this plexus is frequently inside the nodule, and cannot be preserved. So the nerve sparing techniques may work only when the fibers of the hypogastric plexus are not inside the nodule, because otherwise they are too thin to be preserved. Now, if we speak about the endometriosis of the parametrium, we have 2 types of nerves, big nerves involvement. So now we will speak about the 4 sacral roots and the sciatic nerve. So you speak about big nerves, and we overlook the thin nerves such as splanchnic nerves and hypogastric nerves. So there are 2 types of nodule. You may have the first type, represented by very big nodules of the parametria. So this big nodule which infiltrates the posterior vagina, the parametrium, and the rectum. They are the most frequent, 85% in my series, and they come to compress first the S3 and then the S2 or S1, and the symptoms are related to the pudendal nerve. The pain is into the pudendal nerve, and rare in the sciatic nerve. So the patients do not have pain into the leg, but rather into the buttock and the perineum. So this is the most frequent case. You see nodule like this. Frequently, very frequently, they also infiltrate the rectum, because the rectum is just closed. Then we have the second type, type 2 nodules. Here the nodule is much more laterally. It's on the pelvic wall. It is far from the rectum, but it is very close to the sciatic nerve. So here you see, here is the sciatic nerve. The sciatic nerve will be on contact with the nodule, while the rectum, it is much more medially. So this type of nodule are less frequent, 15%. They are rarely involve at the same time the rectum. They may involve the bladder, because the bladder is closer, and the symptoms, the pain is into the leg. There are cyclic pain into the leg, down to the foot, because there is sciatic nerve which is involved. Now, let's see the excision. So this presentation is surgical, and it is based on my experience, where I try to try a systematization, try to find some steps, very standardized steps, which helps to do the surgery safely. And for the big nodules type 1, which involve also the vagina, the rectum, I identified 10 steps, and I advise everybody to follow them. So this type of nodule may not be seen in the laparoscopy if the laparoscopy is done for everything else. For example, a surgeon who comes to perform a surgery for ectopic pregnancy won't see that here there is something wrong. And what's happened? We have a big nodule into the depth, and we see only the tip of the nodule like an iceberg. And this nodule involves the parametrium and down to the sacral roots. It also may involve the rectum, and it may also involve the contralateral parametrium, and in this case it is almost sure that the patient will have some difficulties to void the bladder, because the splanchnic nerves of the bladder are involved on both sides. So this patient should push to void the bladder, and it is very likely that after the surgery she will need to push even more. Now, the first step of this surgery is the ureterolysis. So the surgeon should start on the tip of the iceberg to release the ureters. From while to while the ureter may be involved by the nodule, but we just do the ureterolysis, and if you have to carry out a reimplantation or a resection, we'll do it at the end of the surgery. So first step, ureterolysis. Second step, ureter is here. We are going on the contact with the rectum, and we'll open the pararectal space. So we'll release the rectum, and if the nodule infiltrates the rectum, we'll cut the nodule in two parts, the major part on the parametrium and the smallest part on the rectum, and we'll treat it at the end by either colorectal resection or disc excision. So you see, we go on contact with the rectum. We'll try to preserve all the nerves from the inferior hypogastric plexus is located here, you see. So we are going on contact with the rectum. Here you see the rectum, the white wall of the rectum. And then once the rectum is completely released on the lateral side, we go to the third step, which is the releasing on the rectum on the anterior wall. And here you see the nodule involves also the vagina, so we will cut the nodules in two parts. We can help the dissection by inserting the index, the left index of the surgeon into the vagina, and you feel very well that here is the rectovaginal space, healthy, located below the nodule. Here is the vagina, here is the rectum. So we'll separate completely the rectum from the vagina. This is the first step, and at the end of the third step, the rectum can be pushed contralaterally, and this rectovaginal space is opened down to the levator ani muscles.
During the fourth step, the hypogastric nerve may
Sorry.
be easily...
Now we have the fourth step. The fourth step is we try to identify the hypogastric nerve, which is located here. You see here. So there are the sympathetic fibers which come into the inferior hypogastric plexus. From while to while we dissect the nerve, but we cannot preserve it. From while to while we have to cut it because it goes into the nodule. However, it is always useful to try to preserve it. It brings information about the filling of the bladder. So it is very important for women to know that they have to go to void the bladder, otherwise, without the hypogastric nerve, they will go twice a day when they have pain into the abdomen due to bladder which is too filled. The next step is the opening of the peritoneum on the contact of the promontorium. So we open here is the ureter. We'll open the peritoneum. We'll have a look medially on the superior hypogastric plexus and the origin of the hypogastric nerve. And we'll have also a look laterally on the origin of the hypogastric artery and hypogastric vein. So the peritoneum should be completely open transversally. Then we can go to the sixth step, which is of major importance. This is the dissection of the hypogastric artery and vein. So, once the peritoneum was opened, you will see the origin of the hypogastric artery and vein. And my advice is to always systematically dissect them. Because once we were on contact with the nodule, we may have a hemorrhage from an artery or a vein. And it is very, very difficult to control the hemorrhage if we have not dissect proximally the vessels in order to put a clip or to coagulate. So we have to take 10 minutes to completely dissect. You see here very well the hypogastric vein. So we have to dissect it completely in order to be able to control a hemorrhage. The seventh step. So we dissected the artery and the vein, and now we are on contact with the nodule, and we see very well that the vessel goes into the nodule. Here you do not hesitate to clip the vessels and to cut them in order to avoid any injury, inadvertent injury during the dissection of the nodule. And here you can see that this is an injury of a vein. I did it on one of my first cases, and the injury, once the hemorrhage occurs, it is very, very difficult to control it. So here, fortunately, I could control it, but in 2 cases, 5 years ago, I had to convert to open surgery because it was impossible to control a hemorrhage because the lesion, the injury was behind the hypogastric vein. The patients had previously surgery for colorectal endometriosis without removal of the parametrial nodules, so there were huge fibrosis, post-operative fibrosis. Anyway, as I did not dissect correctly the artery and the vein proximally, I could not control the hemorrhage. So do not hesitate to control these vessels before their entry into the nodule, because anyway we have to cut them. The 8th step, now we are on contact with the nodule. You see here is the nodule, or on contact of the nodule, the sacral roots are here. Now it's time to dissect the sacral roots. And here we have the identification of sacral roots. So here you have the ureter, here you have the artery, here you have the vein in blue, and now we'll go on contact with the piriform muscle, and you see here the left 3rd sacral root. It is white, and behind you have the muscle. So here you have one, here you have the second one, and between them you have the muscle. So pay attention of these vessels, which we have completely been coagulated and cut. That's why you can see so easily the sacral roots. Here you have one, here you have second one, and here we'll have they will join the L5 to give birth to the sciatic nerve. So you see there is nothing in the front of the nerves of sacral roots just because I have clipped and cut the vein going to the hypogastric vein. The next step. Now we are on contact with the nodule, but from while to while there is an actual infiltration of sacral roots here. So now we have to take the scissors and to shave the sacral roots in order to remove the disease. Here the surgeon should decide if he cuts deep into the nerve with the risk of sequela, or he stays superficially with the risk of persistent post-operative symptoms. So I cannot give you a rule. I always try to excise completely, taking into account also the risk of post-operative sequela when the nerve is completely cut. There are not major post-operative sequela if you cut the S3, because you may have an anesthesia in the pudendal area. However, if you cut S1 or L5, you may have big troubles in the muscles of the leg, because these fibers go into the sciatic nerve. So you should take care before cutting inside these nerves. So at the end of this 9th step, the sacral roots are completely released. You see here S1, S2, S3. The nodule is here. Now we have to remove the nodule. So during the 10 steps, we have to turn around the nodule and to remove it completely. So this is not very standardized step. You have to do everything you can to remove it. But here the surgeon will employ his knowledge on anatomy, and he has to do this with a lot of patience, not into the rush. So this kind of surgery may take 3-4 hours. So here you have an anatomy. You have the external iliac vessels. You have here the obturator nerve. Here is the sciatic nerve. You are on the left. Here is the ureter. Here is the ureter, and here you have the third sacral root, and you see how it goes on contact with the sciatic nerves, and here the sciatic nerves will go out. The pudendal nerve should be here. So from while to while I told you that the bladder may also be involved. But also we may have an involvement of the muscles. So yesterday I had a very difficult surgery to remove a nodule, big nodule into the psoas muscle. You may have also nodule into the piriform muscles. So the excision may be very, very, very difficult. So these are the 10 steps I propose for the removal of type 1 nodules of the parametrium. And now I will just give you a short 5 minutes about the excision of the sciatic nerve or of the type 2 nodules, as they are less frequent. I will give you a short movie in 4 minutes, so please pay attention of the 10 steps I imagine to remove the rare nodules of the sciatic nerve, which are located much more laterally. So the first step is opening the peritoneum outside laterally from the external iliac vessels. So now we are on the external iliac vessels, or much more lateral. So here you see you have the psoas muscle and you have the genitofemoral nerve. The second step, we go deeper on contact with the psoas muscle. We push medially the external iliac vessel and nerve, and we external iliac artery and vein, and we go into the deep to look for the obturator nerve. So until this point, the colleague who carry out the cancer, gynecologic cancer, used to do. But in endometriosis, you have to go deeper, and below the obturator nerve, you find the obturator vessels. You're still on the left side. We have to clip them and to go even deeper, and below 1 centimeter below the obturator vessel, we'll find the lumbosacral trunk here. This is the origin of the sciatic nerve. Here we are on the other side, on the right side, obturator nerve, and sciatic nerve. So at the end of the 4th step, we identify the sciatic nerve going laterally from the external iliac vessels. And now, for the 5th step, I propose to open the peritoneum also medially, as our colleague do in gynecological cancer, to perform the lymphadenectomy. And then we will find again the obturator nerve, and below here you will see the sciatic nerve here. And the sciatic nerve, it goes laterally and will go out from the sciatic foramen. And here you see the nodule. So from while to while there are some vessels going outside. They should be clipped and cut. And also medially you have the pudendal nerve here. It goes into the front in the canal of Alcock below the sacroiliac ligament. And then the dissection continues. So here we have the sciatic nerve. The dissection continues by cutting progressively, releasing until the bone, until the sciatic spine. They are vessels, not major vessels, but they should be controlled progressively. So here you have the left sciatic nerve, and the nodule may be large like this. But at the end of the surgery, which is important to release completely the obturator nerve, which is responsible for the motricity of adductors, and also the sciatic nerve here. So the first 10 steps I presented for the type 1 nodules are now available in a video article which is in open access in Fertility and Sterility. So if you have a look at the Fertility and Sterility, you can see the 10 steps of the dissection of parametrial nerve responsible for compression of sacral roots, while the 10 steps of the sciatic nerve are in preparation for another video article. So in conclusion, the deep endometriosis of sacral plexus exists. So now, honestly, I manage since 2 years. I have had to manage each month or even 2 cases a month, and the majority of cases the patient have previously had IVF management. I don't want to say that the IVF made growing the nodule, but there are patients with a long period of time with periods or with stimulation, so they are trying to get pregnant. They are symptomatic. They have pain into the buttock, into the leg, into the perineum. They have some difficulties to void the bladder. They have constipation. These are symptoms of the involvement of sacral plexus and the inferior hypogastric plexus. So the majority of type 1, meaning that the sacral roots are involved, the rectum and the vagina are involved, and less frequent the sciatic nerve. So the sciatic symptoms are less frequent. The approach on sacral plexus is, depending me, standardized, should be prudent. It requires a good knowledge on anatomy of the retroperitoneum, but you have very good anatomists in India. I saw tremendous presentations from several colleagues from India, so you have very, very good surgeons and anatomists. And it is very important to attend surgeons with consistent volume in this surgical field, so you're very welcome in Bordeaux, you know very well. And there are 3 major tricks and tips: the awareness of what may happen when you perform the surgery, care taken to prevent any injury of vessels of nerve, and humbleness, because the complications may always occur. So you can see a lot of such movies on my YouTube channel. There is a folder Sciatic Nerve and Sacral Roots, or on my LinkedIn account. Of course, you are very welcome in our small clinic in Bordeaux, because we have a huge activity in deep endometriosis of the colon rectum and the sacral plexus. And I would welcome you to the European Congress, Endometriosis Congress in Bordeaux, the 6th and the 7th December 2021. I would be so pleased to receive you in Bordeaux. So thank you very much for your kind invitation, and I would be very pleased to answer your questions.
Thank you, Dr. Roman. It was a wonderful deliberation on the deep endometriosis. Most of us, the infertility specialists, are scared to think of this surgery for such deep endometriosis, but I think you have really done justice to this deep endometriosis. And now we are looking for a question from the audience. The one question in the chat box, which is there.
So let me see. So the questions, yeah.
I will tell. There is a question from Dr. Mia A. Valerial, that is there any role for the injectable progesterone in the treatment of endometriosis?
Yes, so the medical treatment, is always very useful. I know that there is the progesterone called Depo-Provera in injection. It may be injected every 3 months, Honestly, in France, it is very rarely used. So in France, we use the contraceptive pills, estrogen and progestative, the progestins. We use the progestins. We use the progestins, and we may also use the GnRH analogs. But of course, there is a role for any medications which may block the ovaries.
Oh, thank you. I hope it will be useful. This answer is useful. The another question, Dr. Roman, is there that please guide for bowel preparation prior to excision. You must be preparing the bowel. So
Sure.
how the bowel is prepared?
So we ask to patients to respect 5 days free residue diet. So we have list of what they can eat and what they cannot. Then the day before, they will drink an X-Prep. I don't know the English name, but it's something, a liquid, 1 liter of liquid, and the bowel will be clean. And the morning of the surgery, they also have to do an enema. So the bowel is usually clean at the point that we can perform the nose, the natural orifice specimen extraction, except it in women with very, very large nodule responsible for stenosis or subocclusion.
Yeah.
Because this woman very rarely can clean their bowel because of the obstruction.
Good, thank you. So one more question is there, that if you remove 2 discs, which one do you do first, the upper one or a lower rectum, and why it has to be removed?
Yes, so if we have 2 nodules on the bowel, one on the lower rectum and one located upper, we have 2 solutions. Either we remove each one separately and we conservate the intermediate healthy rectum, or we remove them both into a long colorectal resection. We also try to remove separately, particularly when the lower nodule involves the lower rectum. And this in order to avoid the risk of low anterior rectal resection syndrome or LARS syndrome, which is very, very embarrassing for the quality of life of patients. So yes, we can do a disc on the rectum and a disc on the sigmoid colon, or a disc on the rectum and a very short resection of the sigmoid colon. The unique problem is that we have 2 sutures, so we increase 2-fold the risk of fistula. This is the price to pay to conserve 10 centimeters of healthy rectum. And I saw there was another question about the head-back therapy. And this is an excellent question, because each time you give GnRH analogs to block the ovaries for endometriosis, it is absolutely necessary, it's almost mandatory to also give an head-back therapy, because it does not decrease the efficiency of the treatment, but it increases the quality of life of patients. So I use percutaneous estrogen, there is in French, it is Estreva gel. And I use it systematically from the first day. And I also, when I give a 3 months GnRH treatment, I also give them a pill during the first month in order to avoid the flare-up. Because if you give a GnRH analogs, it starts by stimulating the ovaries, and the patient may have periods, very heavy periods and painful periods, 2 to 3 weeks after the surgery, if you after the injection. So if you gave her also a pill, this flare-up usually does not occur.
Dr. Roman, I'd like to ask you, in your experience, which is the worst type of post-surgical problem you have faced in this patient when you're trying to resect the sacral?
Well, I think that the worst, I will show you immediately. Because the worst situation, it was in this patient. So I start the movie. This one. So here it was a patient with a very, very big nodule involving the vagina, sciatic nerve, obturatory nerve, and bladder and the ureter. Okay, so
Okay.
this is the status at the end of the surgery. The nodule is here. It involves the bladder. So you see the sacral roots. You see here the obturatory nerve. It was inside the nodule, so you see it is a bit blue. So she has a motor trouble for 2 weeks from the adductor muscles. And the problem is that during the surgery, we released the sacral roots and the sciatic nerve, so it was okay. We have to cut the ureter along with the bladder. We sutured the bladder and we reimplanted the ureter. And we also carried out a large excision of the vagina. The problem is that 3 days or 4 days later, the bladder catheter, which was maintained for 2 weeks, was obstructed by some tissue. So she had a big, the bladder filled in, so she did not fill because there was a trouble of the filling, and the suture of the bladder broke. So we have a uroperitoneum and then a fistula between the bladder, just around the former meatus of the ureter, and the vagina. It was a hole like this. It was very, very, very difficult to manage. It took 3 months to manage. It was terrible. This, I think, is the worst. Also, I had fistula of the bowel, but fistula of the bowel with a stoma, it may be managed. But this fistula, vesicovaginal fistula, was terrible to manage.
I think it is really a lot of experience on your part to deal with such varied problems during the surgery.
That's why I said that the awareness is very important. So the surgeon should know what kind of problem may happen and how they should be solved. So it is impossible to perform a surgery and to be surprised by a complication you have never expected.
You have another question, but it's not concerning deep endometriosis. This is concerning can endometrioma be accidentally found during cesarean section? I don't think it is during the deep endometriosis. If you like, you can answer it. Can endometrioma found accidentally during cesarean section? How you can deal with it?
That is very strange because the first consultation this morning was a patient like this. Okay. So a patient 30-week gestation. The ultrasound revealed a 9 centimeter endometrioma behind the uterus into the sacrum. And the obstetrician said, okay, we'll perform a cesarean section, of course, because we have the delivery is impossible due to the endometrioma, and I will remove the endometrioma during the cesarean section. And my advice is no, certainly not, because the endometrioma is very vascularized. So if we try to perform a cystectomy during the cesarean section, these are the worst circumstances we can imagine. So it will bleed. There will be a lot of coagulations, and I think that this ovary will be dead at the end of the surgery. Furthermore, the surgery will be incomplete because nobody knows which additional associated localization exists in this pelvis. So I think I said cesarean section without taking the uterus outside the abdomen in order to avoid to break the adhesions behind the uterus. The obstetrician may aspirate, just pick a hole and aspirate the content of the endometrioma and live like this. pill after the delivery, MRI 3 months later, and then we'll see and we'll plan a surgery, complete surgery once.
I think that is an excellent advice. Otherwise, it is very tempting to remove the endometrioma during CS. The surgeon feel very tempted, but one has to be rational and.
I think if the endometrioma is found during the C-section, do the C-section, leave the endometrioma behind, and come back in laparoscopy later. It's much better. I suppose.
Dr. Roman.
Yes.
Very beautifully you explained the steps of 10 in a type 1 and type 2. It was a real excellent talk, I must tell you. But I just want to know, in a follow-up, your patient comes sometimes with dysphagia or dyspareunia after the surgery?
Yeah. So
what kind of morbidity you have?
Yes. So I have just published an article in the Journal of Minimally Invasive Gynecology, and it is available in open access. So 1 year after the surgery, the patients with type 1 nodule, which was removed, may have dysphagia. I don't remember the percentage, but it may happen. Let's say 20%. 5% of them needs self-catheterization because the bladder does no longer work because of the section of the destruction of the splanchnic nerves of the bladder.
Neuropathy.
Yes. Then everybody overall health is improved, but some of them also may keep some symptoms, some paresthesia, some hypoesthesia in the pudendal nerve. So there may be an hypoesthesia of the perineum, I think in 20%, like this. But if you ask the patient if the rectovaginal fistula, it's about 10%. So they're very, very tricky surgeries with tricky complications. But what I want to emphasize, if you have a patient, young patient with deep endometriosis, very, very severe, and you feel that this patient needs a surgery, it is better to perform it earlier than later. So postponing the surgery just because the patient is too young will lead ultimately to a surgery much more aggressive with a higher risk of complication a couple of years later. So I think that if you have a patient 25 years with a nodule like this, don't hesitate to perform the surgery first, because later will be much more difficult and the complications risk will increase like this.
Very rightly said, because the way the deep endometrioma is sitting, if you compare the before the surgery, what type of sign and symptoms she has, after surgery, definitely it will be very minimal and it should be performed as early as possible. Very rightly said. Thank you.
And
there are few.
And what I showed you, what I demonstrated in a recent paper, I carried out a randomized trial comparing the colorectal resection to disc excision and shaving. This is the randomized trial. It has been published in Human Reproduction in open access. 4 years, so that the surgery was carried out for symptoms. 4 years after the surgery, infertile women who are known to be infertile before the surgery, were pregnant in 74% of cases, and the majority of pregnancies were natural. So in my opinion, it is not logical to say to a patient, you're too young to have the surgery and you can be infertile after the surgery. If the surgery is well done, the probability of pregnancy after the surgery is very similar with probability of pregnancy after 3 or 4 IVF cycles without surgery. But after the surgery, I have of pregnancies are natural, and the patients do no longer have the disease.
Do you like to give some GNRS type of injections before surgery or straightway you take?
But I have given for years GnRH analog to prepare the surgery, and I stopped giving it three years ago, and I have not seen any differences between GnRH analog before the surgery and pill before the surgery. So I do not longer use them before the surgery.
Dr. Roman, what about post-surgery? You are using Dynagest for such patient post-surgery?
Yes, post-surgery. If they want to get pregnant, they have, and if after the surgery the patient want to get pregnant, if the endometriosis fertility index is correct, and if they have at least one fallopian tube in excellent status, I let them 9 months to try to get pregnant. If the endometriosis fertility index is bad, I give them a pill and I refer them to an IVF colleague. And the first line pill effectively is the Dynagest. But in a majority of cases, in order to avoid side effect, I ask them which is the pill you have already taken and you with perfect results, no side effect. And if they give me the name of the pill, I tell them, okay, you take this but continuously. If they have no preference, I give them the Dynagest.
We have another one question. Is there any increase in ectopic pregnancy with ovulation induction with endometriosis in spite of a laparoscopic procedure done already? The patient with endometriosis who has been operated upon, not deep endometriosis, normal endometriosis.
I did not understand the question.
Is there any increase in ectopic pregnancy with ovulation induction in a patient with endometriosis? We are not talking of deep endometriosis, normal endometriosis.
Honestly, yes, it might be if the fallopian tube are involved, but in my experience, in my articles, I always have a first table one with the past history. Okay. And in my opinion, I have never been set up by a very high rate of ectopic pregnancy before the surgery. So maybe, but I did not observe this very frequently.
So after the surgery, Dr. Roman, when do you send these patients to your IVF colleagues? How long?
In two situations. If during the surgery I see that the fallopian tubes are either absent or destroyed, or I remove them, I send them to the IVF. Or if I give them 9 months to try to be pregnant naturally and they are not. After 9 months, I give them a pill, I refer them to the IVF. So a half of the pregnancies in my series are due to IVF, and a half are natural.
Another question about surgical procedure. How do you monitor your patient for an immediate post-operative leak after a bowel surgery when you done a bowel resection? How can you monitor your patient for a...
So you have to know that after a bowel resection or disc excision, so when the patient has a suture, there are 10 days at risk of major complications such as the rectovaginal fistula or bowel leakage. Bowel leakages usually occur 5 to 6 days after the surgery. So it is very important if that a patient is managed in Bordeaux and she lives in Paris, she stays in Bordeaux 10 days after the surgery. So you have to check what happens with this patient during 10 days. Now, it does not mean that the patient will stay in the clinic. So they usually leave the clinic day 2, day 3, and then she will have every day for 1 week the assessment of C-reactive protein and white cells, leukocyte. And if we see an increase of the C-reactive protein, she must come back to the clinic. And we have to rule out urinary infection, and we have to rule out the fistula. So she has a CT scan immediately, the day of within 2 hours, and then if we feel that there is no explanation for the C-reactive protein, we also carry out a laparoscopy in order to fill the rectum with blue liquid and to see if we have a leakage or not. And if you have a leakage, we put a stoma. If there is no leakage, no stoma.
That means you have to monitor such patient at least minimum for 10 days after surgery.
Yes, usually if at day 7, day 8, the C-reactive protein is less than 10,
yeah,
I tell her everything is okay. If the C-reactive protein increases, you have to take care. I have already published this 2 years ago in the British Journal of Obstetrics and Gynecology. There is an article about the interest of the C-reactive protein after the surgery for colorectal endometriosis. So the threshold I found was 100 at day 4. If the patient is over 100 at day 4, you have to take care. She may have not only the leakage, she may have urinary infection, an abscess, pelvic abscess, but the leakage should be ruled out.
Thank you. Dr. Sudha, you have more questions?
No, I think we have covered beautifully, and lovely talking to you, and lovely step 10 of the deep endometriosis. You have really shown the people who are doing endoscopy will get the very beautifully all the tips how they should proceed further. It's excellent talk, Dr. Roman. And again, I'm inviting you for the December 10th to 12th, our Fertivision, which is the excellent national conference with the more than 50 international speakers. So if it is virtual, you please keep your time for us to join.
If it is virtual, I will be there. If it is not virtual, I cannot come because I have my European Endometriosis Congress where you are very welcome, of course.
Yes. So I understand you are quite busy. You will be busy during that period. It is excellent. So I would like to thanks to BSV joining with IFS and giving us a beautiful platform by Science Integra to conduct this was the fourth IFS BFS initiative in the month of April, in the month of March, about this endometriosis month. And we are really we want that the endometriosis, the way it is a complex disease, so awareness should be there in each patient and even the doctors how to deal with all these things. So I just want to thank again to Dr. Roman for joining us. Thank you so much.
Thank you very much, and I wish you a very, very pleasant meeting and webinar, and I hope to meet you not virtually, and I meet you soon. Stay healthy, and thank you very much for your kind invitation.
Thank you so much. And thank you session for conducting and giving us a very excellent platform, and our delegates, more than 2,000 he has already said about it all over the globe. They have joined and they must be benefited by this. Dr. KD, you want to say something about?
I think it was excellent deliberation by Dr. Roman, and the eye opener for me as a fertility specialist. Eye opener.
Thank you.
Thank you so much.